Person-centred care is supposed to be an essential feature of UK health policy, yet co-production has been almost entirely absent from the evolution of digital psychiatry. Nell and I are here on behalf of user their group Mad COVID to share evidence on why digital psychiatry does not work for some people, as well as offer suggestions on how guidance can be shaped for the future. To give you some insight into our knowledge, Mad COVID was established in March 2020 as a survivor service user-led group to support people with mental health conditions during COVID-19. We initially established a hardship fund for people with mental health conditions or neurodiversities experiencing financial hardship due to COVID. That hardship fund has crowdfunded over £25,000 and we've awarded just under 200 grants so far. We also have numerous projects through which people have been documenting their experiences, including diaries, interviews, and a podcast. And we even held our own symposium just 2 weeks ago. Through these projects, Nell and I have personally spoken to dozens, if not hundreds of service users across the UK, and we're very pleased that some of their experiences will be heard today. Whilst I'm sure we'll all feel excited today hearing about the new possibilities and advances in digital psychiatry, this enthusiasm must be balanced with the knowledge that hurtling too quickly towards this future is going to leave some of the most vulnerable people from our community behind. Future guidance and the rollout of this technology must be informed by service user experiences and service user-led research. Now's going to take you through some of the barriers with digital psychiatry we've identified as having prevented people from accessing effective care over the past 8 months.
The barriers that we have identified broadly fall into 2 categories. The first could be defined as access requirements, covering digital poverty, executive functioning, paranoia, including technophobia, and privacy. And the second category being efficacy, covering trust, communication, and the therapeutic relationship. Firstly, I'll talk about access requirements, and Ellie will go on to talk about efficacy. Using the term access requirements acknowledges the ongoing duty that providers have to make reasonable adjustments to ensure digital services are truly accessible. It allows us to think of the reasons why patients may not simply be able to adjust to this new way of working. The first issue in access requirements that I'll talk about is digital poverty. We've repeatedly heard from people who report that they're digitally isolated as well as physically isolated. Through our hardship fund, which would be very happy to receive your donations at the end of today, we know that some people simply do not have access to the devices or reliable internet connection that they need to access support. We've granted numerous awards for laptops, tablets, phones, and even Wi-Fi connections. Wendy, who we provided with a laptop through our hardship fund, told us, "Of course, like everyone, I have a phone, but due to anxiety, I'm unable to make phone calls. I do use the phone for games, texts, etc., but due to physical health needs, I'm unable to use it to write more than a sentence or two. So my laptop was an essential for emails, following social media, and the like. I really missed it and found myself becoming even more isolated." The people in our community who are most vulnerable to digital poverty are likely to be those who are most vulnerable to poor mental health, such as those unable to work due to severe mental illness or people with no recourse to public funds. We also know that older people are especially vulnerable, such as those who don't have adequate support to use the technology or those with more severe dementia who may not be able to use it safely, if at all. We have provided financial support through our hardship fund for people in these situations and many more. How will you ensure that patients experiencing digital poverty are able to access digital support? Where will the funds come to help support these patients? The next issue related to access is executive functioning. It can be extremely difficult for people who are more acutely unwell to use technology effectively. This is even more unrealistic when people are required to use multiple platforms across different service providers. Having both experience being acutely unwell, Ellie and I can personally attest to this. Speaking from my own experience, I found it difficult to get used to accessing this new way of working. When my mental health is bad, I find it difficult to remember appointments, let alone how to access them on my laptop. My mental health team has worked with me in using these different platforms, and I find it particularly helpful to be sent a link to the provider right before my appointment, usually by text. It is small adjustments like these that can make all the difference in my ability to access digital care. In their interview, Ali told us, My medical appointments exhaust me and I don't have the capacity to use online video platforms for other things. I do try to use them once a week as I feel bad for my family if I don't, but it doesn't help my mental health. Next, we move on to paranoia. Paranoia can make accessing digital services very difficult. Speaking at Mad COVID Symposium 2 weeks ago, Andrew said, "I think it depends whether you've already developed a trusting relationship with someone. Part of my condition can sometimes manifest in technophobia, so thinking that the computer's reading your thoughts or things like that. So again, it's about doing this in a very person-centered way." Again, speaking personally, my own mental health difficulties can leave me feeling incredibly mistrustful of mental health services and questioning what agenda they might have. Adding digital care into the mix adds another barrier to overcome in order to trust services and work collaboratively with them. A move to digital services must not leave behind people who would be too paranoid or mistrustful to fully engage online. Service users unsure about digital services may be able to use the technology if they've already developed trust with a particular clinician. However, for some people, it may just be a step too far. Indeed, in the World Health Organization's report, Maintaining Essential Health Services, Operational Guidance for the COVID-19 Context, it gives several recommendations about digital mental health. In outpatient settings, it advises clinicians to prioritize face-to-face care for initial management of severe mental, neurological, and substance abuse disorders involving either severely impaired functioning or life-threatening situations. With these barriers to online care in mind, how will you make adjustments to allow people to access digital service? How will you make the decision about who to prioritize for face-to-face care? Will these decisions lead to some people being left behind? We can't allow that to happen. Next, we move on to privacy. No matter where or how we receive care, confidentiality and privacy is extremely important for service users. Some people need a space outside of their day-to-day surroundings where they feel safe to speak about their mental health. As a result of COVID-19, many people have found themselves stuck in extremely difficult, pressurizing, and in some cases traumatic family environments. Whether they have moved back in with their families, are trapped in an abusive relationship, are trying to homeschool young children, or they are just living in chaotic student housing, now more than ever, privacy is a rare commodity. What's more, home isn't always a safe place. For example, someone might be experiencing domestic violence or have a family who's unaware or unsupportive of their mental health. Having sensitive conversations about the difficulties they're experiencing can put people at risk. We've also spoken to individuals who live in generally supportive home environments, but who tell us that demands of childcare or distractions such as your pet or your postman knocking on the door, in other words, the normal ebbs and flows of everyday life, make it very difficult to find privacy or to concentrate for extended periods of time. After all, it is difficult to engage in meaningful conversation when part of your brain is thinking about what that banging coming from the next room is. In their interview, Ali told us, "I find medical appointments hard if family are in the house. I feel like I need to be on my own in the house to have privacy, but that's not always possible, so I end up having to cancel." How will you be sensitive to these environments that your patients are signing in from? If it is impossible for some people, how will you identify and prioritize these patients? The last issue in access requirements that we move on to is GDPR. Beyond the practicalities of finding privacy in our homes, many people have legitimate concerns about GDPR and data breaches. We've heard from service users and professionals about the need for digital platforms to be GDPR compliant, particularly in relation to Zoom. However, little consideration is given to additional factors that compromise GDPR, aside from choice of platform. For example, sessions happening in a room with the rest of the team present. It's pointless to worry about technological hurdles of data protection if inadequate GDPR practices are happening in the workplace. In their diary for us last week, @Relapse Rover wrote, "I communicate with my care coordinator on the telephone or video conference. I can hear the other people in her office talking and once heard a pigeon falling down her chimney when she was working from home. She occasionally responds to the people in her office, and last week someone brought her a cup of tea in the middle of our appointment. It would be better if she went into a private room, as she would do if I was seeing her in person. It feels less private and secure." GDPR intentions are always good, but nevertheless, we know that breaches occur. Therefore, what are you going to do to be transparent with patients about how their data is handled and the risks involved?
Now I've spoken about access requirements, now I'm going to move on to the second category, efficacy. There are a number of factors we've identified that impact on the efficacy of digital psychiatry. Firstly, let's talk about trust. Whether service users have made the transition from face-to-face or been trying to build rapport solely through digital psychiatry, people like Stacey have told us it's not remotely the same. In a quote taken from their interview, Stacey continues, "In the group setting, we weren't meant to talk about personal issues, just the skills. And I hadn't had the one-to-one time with the facilitator to build up the kind of relationship needed to do that anyway. Now that we're doing phone calls, I'm supposed to talk in more detail about specific personal issues I'm trying to address, but without that relationship and precedent, I feel quite awkward." Developing interpersonal relationships is difficult for people with mental health conditions, particularly people who've experienced bullying and discrimination because of their identity or diagnosis, whether from within the NHS or elsewhere. There were all kinds of non-verbal signals which are missing through digital interactions that would usually help in developing those trusting relationships, such as body language or even clothing and jewelry. These are indicators that would usually help us to build up a picture of a person's character or background. Now we must rely solely on the 3-foot window they choose to present. Speaking from personal experience, I sought out new treatment and a new therapist at the beginning of June. Our relationship has been built entirely through digital interactions. Whilst I liked my new therapist immediately, it took around 8 weeks for me to begin feeling comfortable with her, and at least 12 weeks to fully trust her, enough that I now feel safe and am able to be entirely open. I believe it took longer for us to establish that relationship because of the limitations to digital interactions. Understanding and compassion from my therapist about how different and potentially difficult this process was for both of us definitely helped me to overcome those barriers. But ultimately, establishing trust and a strong rapport with providers through digital services simply takes longer than face-to-face. This becomes even more critical where care is time limited. It is unacceptable to us that patients who are commissioned funding prior to or during COVID-19 have been expected to achieve the same outcomes from their treatment within the same time frame in light of a global pandemic and huge adjustments and limitations to their support. What will be done to accommodate the difficulty some patients have building rapport through digital psychiatry? Next, we come to communication. As we've highlighted, effective communication goes beyond good internet connection or the words that are exchanged between providers and patients. Providers must be reliable in recognizing non-verbal cues from patients, as well as when patients are masking emotions or other signs of being mentally unwell. For example, face-to-face, it would be very difficult, if not impossible, to disguise poor personal hygiene. Patients who are more acutely unwell are particularly vulnerable in this regard, such as those with eating disorders who may want to hide weight loss, or those experiencing paranoia who are not inclined to accept treatment. Avoiding intervention is often a symptom of severe mental illness. Robust safeguarding, including establishing specific early warning signs for digital psychiatry, is crucial to protect high-risk patients. As Alex told me in their interview, "I don't really deal with change very well. I like to present that I do." Currently, there are no training requirements or curricular-specific training for digital psychiatry. It is essential that practitioners can demonstrate digital literacy and good clinical practice using this technology. And beyond competence, you as providers need to feel confident using this technology. Poor communication carries huge risks for patients. As Robin said in their interview, "The one time I managed to get through to the community psychiatric nurse, she told me to relax, go and make a cup of tea, and prescribed antipsychotics and benzos. The benzos which I'd previously been weaned off because I'd developed an addiction to them. There's no doubt she's aware of my history, but that doesn't seem to count right now." Remote support must be taken as seriously as face-to-face. Having been used to phone calls being seen as somewhat less urgent for so long, it's important to remember that digital services may be the only care people are receiving at the moment. When will training requirements and safeguarding protocol for digital psychiatry be implemented? And what involvement will patient representatives have in establishing such measures? And our final point on efficacy is the therapeutic relationship. I hope by this point we've already helped you to imagine a number of scenarios and barriers, some within your control and some beyond it, that compromise the effectiveness of digital care. It's because of those barriers, and more often than not a combination of several, that people have told us the therapeutic relationship is not the same. Ali told me during their interview, "I met up with a new person by video chat this week. It didn't go well. It felt very clinical and that they didn't understand me. They don't seem to have thought about how support could be adapted via video message. No clear directions of how things will go other than a quick catch up." Even after patients and practitioners become competent and comfortable using this technology, some care will still need to be delivered face-to-face. In the context of a pandemic, when patients are in increased risk of relapse or reoccurrence of symptoms, it is especially important that mental health providers are able to recognise vulnerable patients and maintain face-to-face contact. This was echoed by the World Health Organization in their report, Maintaining Essential Health Services, Operational Guidance for the COVID-19 Context. It advises outpatient services enhance outreach care for isolated people with severe mental, neurological, and substance abuse disorders as needed. Ensure home visits are maintained for specific situations, e.g. care of older adults with MNS disorders. During their interview, Stacey said, "I only have a few more sessions to go. And while I feel it has helped somewhat, sadly, I don't think I've got the benefit from it that completing the group sessions would have given. I'm worried about having to redo the treatment in the future and feeling like I've failed because one go wasn't enough." As service users, this fear of failing that Stacey speaks on should not be ours to hold or to internalize. Speaking from personal experience, the sense of shame and responsibility which that can lead to is toxic. It is your responsibility as providers to ensure that you are delivering effective care and that service users do not feel this way. What will be done to ensure patients who report digital care is not effective for them are taken seriously and that they are able to access face-to-face care instead? Now on to our suggestions. The World Health Organization recommends that mental health services be enhanced and strengthened in the pandemic context. We agree. This applies to the delivery of digital mental health services. They must be enhanced and strengthened. As we stated previously, we must not hurtle towards an ever-increasing use of digital psychiatry in assessment, management, and treatments to the detriment of a substantial cohort of patients. We've compiled some recommendations in relation to the issues that we've discussed, which we think will help.
To assist with access requirements, we recommend that protocols around discharge after so many do not attend should be suspended. If someone does not attend their appointment, try different ways of contacting and supporting them to resolve the difficulties that they're having. It is helpful for more than one platform to be used for patients to choose from. Send emails and/or text reminders before appointments as needed by the patient. These should come from the same contact number and email every time. Face-to-face appointments should be available to those who live in digital or poverty or whose condition, for example, paranoia, or circumstances, including a lack of privacy, mean that digital consultations are inaccessible to them. In inpatient settings, enable remote family support if visiting is suspended.
And to assist with efficacy, we recommend that digital care should only ever be part of a suite of engagement methods. Provisions for face-to-face outpatient care should be ring-fenced. Recognise that time limits for therapeutic interventions may need to be extended to accommodate for the longer period of time it takes to establish the therapeutic relationship. Establish curricular-specific training and quality standards for digital care, with involvement from patient representatives at every stage. These must be rolled out alongside the expansion of digital services, not afterwards.
In conclusion, listening to patients and respecting their needs, including some patients' need for face-to-face support, is fundamental to building trust in a therapeutic relationship and delivering effective care. As much as new evidence is emerging for digital psychiatry, we must not forget that we already have established evidence-based practice for face-to-face care. Mental health service users cannot continue to be the canaries in the coal mine for NHS services. Providers and service users share the responsibility of recognising when digital psychiatry isn't working, but ultimately it's providers who hold the authority to prioritise face-to-face instead. Thank you.
Thank you very much.